This conference will now be recorded.
Yeah, sorry about that. I had to log out and log back in. I apologize, Jim. Excuse me for
No
interrupting you.
problem at all. So my story is I'm 72 years old, diagnosed in 2017. Went through 2017, 2018 through hormonal radiation and chemo treatment. 2019 was a good year, no major issues at all. Felt fine. Feel fine today, other than apprehension of what's next. But had the CT PET scan and identified a lot of hot spots. And now I'm seeing a doctor tomorrow for EBUS. Go down the airway and try to break through and see if we can get some tissue. And most of the folks I've been talking to, as far as my care team, say that tissue is the issue. They want to try to see what's going on because they don't understand it at this time. So that's my my situation.
So, Jim, your metastases were all what we call visceral, all in the tissue, no bone, no lymph node?
No bones, well, lymph nodes, yes, for sure. Yeah, a lot of that,
No bone.
but not no bone. No.
Okay. Now, you said 2019 was a good year, meaning your PSA was undetectable?
Almost, just very nominal. Yes. Yeah, I was when I originally was diagnosed with the Gleason 10. I was told I was in the 5% that basically the PSA is not an indicator of what's going on. I've never had a super high PSA.
What was it at diagnosis?
Diagnosis of 5.
Oh, okay. And did they do a biopsy initially?
Yeah, well, they did do a biopsy of the prostate. Yes, that was where they got the Gleason 10.
Right. And do you know if they did any genetic analysis on the biopsy tissue?
No, I don't think so. I think that basically, I think the conclusion, which I concurred with, was, you're healthy, you're doing okay. So this is aggressive. So why don't we try to throw everything we can at it if you can tolerate it? And that's why I went through the three treatment approaches: the hormonal and the radiation and the chemo, and that did work. I mean, for a year, for all of 2019, I was fine. I still feel fine now. It's just and I guess until we get this biopsy and see what's going on, I guess there's at least a few things that could be going on.
Yeah. So aside from the lymph nodes, did they mention any other specific sites where you had metastases?
Yeah, they was in the chest, fairly extensive lymphadenopathy, and then said no enlarged auxiliary lymph nodes. And then in the abdomen, one site had a 18.2. I'm sorry, gentlemen, I really don't understand what I'm reading, so I apologize. I know I'm sure, very much aware of these things, but I'm not.
It's okay.
Sorry.
It's all right. Does it
So
give units for that 18.2?
Yes. That was a SUV max of 18.2.
Oh, okay, yeah.
And that was in the abdomen.
Right. Okay.
In the chest, I had 8.4s and 6.5s as far as SUVs.
And so these are all lymph
I'm
nodes.
trying to understand what.
These are all lymph
Yes.
nodes in the chest and abdominal region. Is that right?
Yes, they're saying that the impression there was trying to differentiate between metastatic disease versus lymphoma.
Oh, okay. So
So
maybe that's what they'll be able to determine after they get snippets of the tissue with the
right, they're
endoscopy.
supposed to,
Yeah.
and that's supposed to take place this Thursday. So a few days. I'll see the doc that's doing it tomorrow.
Okay, I would guess that if you had lymphoma, there would be some indication just from a blood draw, the types of cells you have, types of white blood cells you have. Did they say anything about your blood? Anything unusual or abnormal in your blood cell morphology? No?
No, the blood's pretty much all along has been coming back okay.
Okay.
And my father had leukemia, but I don't know. That's
Yeah.
but,
Okay, so what type of ADT did you have? Hormone therapy, what type?
oh gosh, I'm sorry to hold you here, Joe. I had
Lupron, Luprolide?
okay, hormone.
Are you still taking it now?
No, it was Elgard,
Eligard.
Eligard, Gard. No, I had 3 treatments, and basically the last one I had was well over a year ago.
Only 3 treatments. Huh.
Let me see, I'll get the dates. Eligard.
And were they 3-month injections? Do you recall?
Yes,
Okay.
yes. And I had the last one on May of 2018.
Okay. And the radiation
sorry.
therapy, do you recall what type that was?
Other than it was 26 days.
26 days of radiation?
Yes. Of course,
Probably.
weekends off, but for 26 days, and that was in the middle of 2017.
And do you know if they just radiated the prostate or did they radiate the whole pelvic girdle?
No, it was just the prostate, focused on the prostate.
Okay. So currently you're not on anything, no drugs, no treatments. You're just waiting for the results of the biopsy.
Correct.
Okay. And where did you say you were going? Who were you seeing? Your doctor,
Well, my oncologist is Dr. Marc Chernoff, and he's in Philadelphia at well, the hospital are affiliated with his Holy Redeemer Hospital it's in Meadowbrook, which is just outside of Philadelphia.
Okay. And do you know if he is a specialist in genitourinary oncology?
No,
Is
I
most
do not.
Okay. You don't know if most of what he does is prostate cancer?
No, I don't. I'm sorry.
Okay. All right. Well, Peter, you have any?
I'm sorry. My urologist and my oncologists have been very proactive and helpful. I'm not although I didn't, you know, I've had the urologist for a long time, and then he put me on to the other players, and that's where I'm at now. So I never really challenged things, or I kind of, you know, I was always given the opportunity. It was my choice, but and I felt comfortable with their guidance.
Good. Okay. I'm going to invite the other guys to ask questions or offer some advice. So we'll start with Peter.
Yeah, Jim, interesting story. I don't meet many, I'm a Gleason 9, but I don't meet many Gleason 10s on this, and it's a very aggressive disease. Just listening to your story, that was my first question, was who's treating you. There are a couple of good facilities in the Philadelphia area that specialize in cancer. I'm spacing out the names of them right now, but you can where you can find a genitourinary medical oncologist, one that specializes in prostate cancer, because I suspect that there's some treatments that maybe you should be looking at or have looked at that maybe you're not getting. So one thought is that you probably should get a genetic test, because I'm suspecting that you're which I might be wrong, I'm suspecting your chemotherapy was just shooting with docetaxel. It didn't have any genetic, because they didn't think you had a genetic component, so they didn't give you anything extra for it. But was that true?
Yes, I think you're
right. Okay, and did you ever get a second line anti-androgen? Were you ever prescribed Zytiga or Xtandi or anything else beyond the just the shot?
No, just a shot in the belly 3 times over the a year and a half. Or
yeah, well, if it was me, even though you have some allegiance and you feel comfortable with your oncologist and your urologist, I would seek more professional help that specializes in prostate cancer. You're close enough to some really good places, and see, it might be time for to go back on something like Zytiga or Xtandi or something, and seek other ways to knock this down. That would be me. Okay, that's all.
Well, thank you. So now you had mentioned you knew. I know Philadelphia. There's the Prostate Cancer Center and University of Pennsylvania and Jefferson are the primary cancer treating hospitals in the area.
Yeah, Thomas Jefferson has some good people.
Okay, thank you. Now, I've never made those inquiries, so I'll have to do my homework to find out how you go about, I guess getting a second opinion.
Right. I'm sure you've got good insurance. You're on Medicare and so forth, right?
Yes.
Good.
You mentioned that you took a PET CT. Was that a PSMA PET scan?
It was PS, yes. PS PET 0049.
That doesn't ring a bell for me.
Just PS, nothing else?
PET tumor image CT SKL thigh PS PET 049. That's what it says, clinical procedure.
Anybody recognize that?
PET tumor image CT SKL THIGH PS dash parens PET 0049 close parens.
Well, okay.
Len, I'm just going to jump in there because I'm trying to listen and I'm also on hold here.
Go ahead.
I want to cut to the chase. You need a different doctor. Absolutely. You're going to have to, I mean, if it were me, I'd be shifting my medical care. I'd suggest Dan Geynisman, Geynesman, who I believe is at Fox Chase. I think that Joel can probably confirm that.
Sam, and I'm sorry, the last name was?
Geynisman, Geynesman. I believe that's correct. I'll look it up. I'll try and put it in. I'm sorry. I do apologize.
No problem.
I've got a mini tech crisis going on here.
No.
And I can't be without a printer for the next 7 days, which is I'm just trying to solve that at the same time.
No, please.
There you go. John Ivory has put it in the chat window. If you press the little bubble at the top on the right-hand side, that will open the chat window, and you can see the link to Geynisman, to Daniel Geynisman in there. Do you see the chat window?
Yes.
Okay, so Geynisman is in there. That said, if your doctor is Chernoff, he's just not on top of what's going on. He doesn't even need tissue right now. Tissue is not the issue, because we can do it with blood. We can do a liquid biopsy, and we can draw blood, and we can analyze your tumor through that, most likely. Not guaranteed, but most likely. So if they're trying to find out where the mutations are, they can do it through a blood biopsy. But I think the biggest issue for me is that this guy hasn't, for a man with a Gleason 5+5 who had radiation, you weren't on hormone therapy for anywhere near as long enough per the protocols. Protocols would say you should be on for about at least 18 months up to 3 years. If you talk to any of the guys, speak to some of the guys who are on this call right now, and find out who has a 4+5 or a 5+5, their initial period on hormone therapy was at least 18 months, unless they had certain issues and came off. The guys who do tend to come off early get recurrence. And when you go and when you see a guy who is, who doesn't have experience in prostate cancer, you run that risk. So, I mean, I just want to say, I see Len has mentioned that the liquid biopsy before, but you said, I know in your introduction, that tissue is the issue. I don't think so.
Okay.
Len, you want to sort of continue and maybe throw it out to the guys and see who else has got something to say?
Well,
Yeah.
Rick, can I say
I would
something?
agree.
Yeah, go ahead.
So
Go ahead.
I guess I'm concerned that you've mentioned the word lymphoma and that they're not able to differentiate.
Uh-huh.
That seems to me something to worry about. I mean, I tend to think that you did not have a PSMA PET scan. You had a radioactive PET scan for metabolism, which picks up highly metabolic areas. And yes, it could be a lymphoma and it could be your prostate metastases, but I think that's got to be dealt with. And I think your best bet to deal with it, and I'll echo what we've told you, is at a really high rate cancer center where they have multidisciplinary people who can really deal with it at a very sophisticated level.
So you're saying is it the biopsy I should not have the biopsy a few days from now? I mean,
I can't say whether you should or shouldn't. If they do biopsy and they detect a lymphoma, fine, then you've got a lymphoma to treat. But the problem is who's going to treat it and in what modality.
Yeah, I mean, I'm sorry. I'm sorry, Jim. I missed that. I mean, if they're uncertain what type of cancer you're suffering from, that's a whole different ballgame. So I wasn't aware of that. I mean, but the other side is, I mean, I think they'd have to do a tissue biopsy in order to see what type of cancer it is.
Correct.
If we knew it was prostate cancer, we could certainly do a liquid biopsy. But I don't think, does anybody know, can you identify the cancer from a liquid biopsy alone? From the,
Liquid meaning blood?
yeah, meaning blood, from the tumor cells, that are circulating. I guess you should be able to, from the tumor cells that are circulating in the blood, can you identify the type of cancer?
I'm sorry, I missed that.
I'm asking Herb or I'm asking Len.
Well,
Okay.
I was just checking
well,
online, and
yeah.
lymphomas apparently cannot be diagnosed with the blood test. And I guess the reason why they're wanting to sample the lymph nodes with the the tissue biopsy is to diagnose lymphoma, or to differentially diagnose lymphoma from prostate cancer. I mean, I hope not, but it's possible you could have two cancers. But I assume, since you said before they radiated your prostate, well, I mean, obviously you responded initially to ADT and the radiation therapy, so you do have prostate cancer. There's no question about that. And they did the Gleason diagnosis. So the other thing, the reason why they're doing that tissue sampling is to see if you also have lymphoma. So you could go ahead with the procedure, or you could tell them you'd like to wait and get a second opinion first, which might be a better idea. And as Rick said, you might want to go to a GU medical oncologist specialist in perhaps the doctor that he mentioned.
Hey, it's Larry Fish. I have a somewhat different opinion. I don't see anything, to start with, going to get a second opinion as a consultant to decide whether you should go for the biopsy that was scheduled a few days from now. It's just going to mean you miss that date and you don't know where you're going to be. You'll be going to another place, seeing another doctor, starting.
Right.
I don't see why you wouldn't just go ahead and get this. It's not a big deal to get a lymphoma biopsy. Why not get the tissue samples, and then when you go to see a second opinion or a center of excellence, they will forward samples of the tissue slides and the other diagnoses. They'll send them all to wherever you're going to go, instead of now postponing everything and moving ahead to a date and a doctor you haven't seen before, and someone's going to start to review your case, and then you're going to start to see another doctor, and they're going to look at it as prostate cancer, and then they're going to be exploring what is going on with the lymph, and then they're going to decide whether or not to do a biopsy, and then you're going to decide where to do that biopsy, and then you're going to schedule it, and who knows where you're going to travel. It seems like you have this thing all set up right now. A few days from now, go and do it. Take everything you have and go to see a specialist, an expert, for a second opinion with everything you have. It seems, just like it flows much more easily that way. That I don't mean to disagree with Rick, never, or Len, absolutely never. But my opinion is, what's wrong with it? Get the tissue sample, have them have slides and tissue, and they'll send it wherever it's necessary.
Okay.
Then go about getting an expert.
I don't disagree with you, Larry. I mean, I do think that, I think our position, go ahead, I'll be right back with you, sorry.
Yeah, no, I understand what Rick is pushing his position, and I think it's the majority of us will agree with our position that you have a high Gleason score. You have a serious potential disease and illness that has a great deal of danger and complexity associated with it. And you should really be under the care, which I'm sure is what Len and Rick and everybody will tell you, you should be under the care of a real expert in the field. It's not something for a typical oncologist. It's really complex and it moves in so many different directions. And there's so many things going on in the field that it seems you really have to plan on doing that. Absolutely, in my mind, I agree. But in terms of this biopsy that's scheduled, go and get it. Even if you ended up getting it somewhere else in 3 months, you're wasting 3 months and you might end up with it anyway. Why not just do it? It's not a big deal. That's my opinion.
No, I think I concur with that. I think I'd like to at least get some definitive answer of what label we're putting on my situation.
Okay. Yeah. I mean, ultimately, you have to be comfortable with the decision. And if you're comfortable with waiting until you get the results of that procedure, then that's what you should do. But with regard to the prostate cancer, I do agree with Rick that you should be seeing a GU medical oncologist specialist, because as Larry said, as Rick said, as I have said, as Peter has said, we've all said this, Gleason 10 is at the very top of aggressiveness, and you want to be in the hands of someone who spends all of his time with prostate cancer.
Okay. Thank you.
Okay. Anybody else care to comment on Jim's behalf?
No, I mean, given the recurrence, I think you might want to ask your physician about going back on ADT even now, because anything you do in the future, if it's prostate cancer, is going to sort of include that.
I'm sorry, I was in another class, but has Jim taken a course of second line androgen or been on a docetaxel or something?
No.
Just
an
original short course of ADT.
Eligard, 9 months.
Eligard. Seems very minimal.
Yeah. That tells us that your current doctor doesn't know how to handle a Gleason 10. He's not following standard of care.
Okay. Were you getting your PSA checked every couple of months?
Not every couple of months. I'd say 6 months, but it always was every 3 months. I'm sorry. It was 3 months.
And it never went up?
No, never went up. It stayed.
Even after going off ADT for a year?
Yes, that's correct. My last PSA, I'm trying to find, it was 0.1.
So Jim, you said you did say at its height it was about 5.
Yeah.
That was when I was being diagnosed. That's what caused the whole.
So what made you go to get the diagnosis? What was the symptom?
Well, I had no symptoms. My my urologist on the annual, it had to do with my urge to relieve myself, being more pronounced than it was before. The urge to go to the bathroom, and the fact that it was the PSA was a little high. He said, let's do the biopsy, which I agreed to. But I really didn't have any major symptoms when we started that either. I mean, it was
just like me, and I'm a Gleason 10.
Yeah. Okay. Well, thank you. I mean, not many of us around, huh?
We actually have two others on this call, Jim. We have Carl Foreman and Herb Geller. And you too, Les? Yeah, that's right. Les is Gleason 10.
Okay, well, welcome,
We
gentlemen.
got plenty of company.
Okay.
I just wanted to also add, being a fellow Gleason 10 person, that I have taken a very proactive approach for my care. I challenge my doctors on a regular basis. I research anything and everything. I want to make sure that I know I'm getting the right care. You know, everyone deals with it differently, but Jim, I really can't tell that you have gotten a hold of your diagnosis, what options you have, and you might be leaving it too much to your doctors, because you ultimately have to make the decision about your course of treatment. And I'm not getting that from you. I almost kind of see you as a deer in headlights. I hate to say. I know you're the first. This is your first meeting here, and we're trying to help you the best we can, and that's the point of this forum. And for me, that was my approach. I had multiple second opinions. I went to several different cancer centers. I live in the New York, New Jersey area, so I went to 4 different cancer centers before I ultimately decided where I was comfortable to have my treatments. I also sought out immunotherapy, Provenge, which I had, and I had genetic testing, which showed that I am BRCA2 positive, which means that there's a particular medication called a PARP inhibitor, which I've been on for the past year and a half and has been very successful in my treatment. So there's a lot of things out there to know and to understand, a lot of resources. I just suggest that you go out there and become more knowledgeable.
Yeah, Jim, it's Larry again. I know I'm speaking a lot, but you know, there were a group of advanced cancer guys. This is the advanced group. We all have serious disease. And the thing that we've learned, all of us, from the doctors among us to the pharmacologists, the researchers, the professors, the lawyers, the intelligent people, the really sick people, for years and years, this is a group of people that have learned that it's necessary to make sure you're managing your care. You know, you may have a quarterback that's going to be your GU oncologist or whoever you choose. You may have a team of professional doctors. They may send you around. But the one person that's going to have to be making decisions, it's going to end up being, you're going to discover it's going to end up being you. You may find a doctor who really you like and they say everything. You follow them like right behind them all the time. You like them. That's really great. That's the best relationship. But most of the time, doctors have their agendas. Their hospitals have their agendas and their protocols they follow. They're different. You need to learn. You will need, and you will do this, learn what's going on around you and what it's like and what other people are seeing. Here is a group. It's national, international, and we're all in charge of our own, responsible for our own health. No one is taking that responsibility. Well, a doctor might try to be controlling and take over. You can follow or not, listen to everything, but in the end, you're going to see that when you come here and you listen to all of us, that we're a group of guys, reluctant brotherhood, who are trying to like push the envelope of the field and our own diseases in order to get the best care for all of us, so we all live and we all live long and well as possible. And it's a great place. You will have to face the reality that someone is not going to blindly lead you down the right path necessarily. I think everybody will basically agree.
Yeah. And if I could add one thing, Jim, last week I was the newbie, and I can tell you that, you know, if you need any assistance or anything getting all of your information together and how to really kind of get your head around this, feel free to reach out to me. I really spent a week of pulling all my information, really making sure that I sat down and I read it, and just preparing myself as to what questions I needed to ask. And at the end of last week's call, I was kind of like, oh boy, there's a lot of lingo, there's a lot of terminology, there's a lot of different drugs. Some, then there's the product name, and then the pharmacological name. Yeah, and so it can be overwhelming. And absolutely, if you need anyone to to ask how, I kind of started getting myself together. Just reach out to me and I can help you out.
Thank you. Appreciate that.
And just one
Yep.
one last thing. This group meets every week. So you're welcome to call in every week, and we'll be right with you while you learn and figure stuff out, and you can bounce it off of us every single week. So there's a lot to learn. You're not going to learn it all in 1 week. It's going to take some time, but we're here. We're good listeners, and everybody here is very, very knowledgeable.
Yeah, on that subject, Jim, if you want to get on our email notification roster, if you can put your email address in the chat window.
We have it, Jake.
Okay.
Jim's already signed up.
Okay, good.
With so hi guys, I am back with you. You have 100% of my attention. Did we sort out a plan for Jim? Are you going to go forward with your biopsy, Jim?
Yes, I think I'll do the biopsy. I think it's this Thursday, and then then when we have the biopsy, and then I have some findings to address and try to, I guess, go out and do my homework with and see who I, as you've suggested, as far as the things I should be doing.
Well, I think that if you're in Southern Jersey, which you must be, because I know you go to the same group meeting that Joe Gallo goes to.
Yes, I'm in Northeast Philadelphia.
Right, Northeast Philadelphia,
but
fine.
Near, not far from Trenton. Trenton's.
Right, but I mean, if you're in that area, then Fox Chase is a good option, and Geynisman is a good option. And frankly, it wouldn't hurt for you to start putting the wheels in motion to get an appointment with Geynisman anyway.
Right, okay.
And he would probably be your entry point. So if you go in and see him, and we know he's good, he's treated other men who's been on this call, and you can get in, and then if he considers that you really need a hematological consult, he'll refer you. And I do want to mention to you that we do have a blood cancer group too. So you might want to go back to the contact us at that point and sign up for the blood cancer group too. Again, we have some really knowledgeable moderators in there, not me, but we have 3 or 4 really knowledgeable moderators that will be able to help you. God forbid it turns out that you need help in that area.
Thank you.
Okay, so we did have
I think if someone knows some of the more recent books that have been written on prostate cancer by GU medical oncologist specialists, I know there's Mark Scholz's book. Maybe we should recommend something for Jim right now so we can get busy reading. Jim, this is our motto right here. You see that? Be your own best advocate.
Yes.
You got to help yourself. Got to educate yourself. We're here to help you, but it
Sure,
comes down to you.
Yeah, I can add to that. I had a appointment today with my oncologist, and I was scheduled for 15 minutes, and then to move into getting my Firmagon test. And I kept him in the room for probably about an hour and like 15 minutes. So, you really do have to go in and ask questions and And he was accommodating, obviously. He put things off, and I had to reschedule my Firmagon until later in the day. But especially, for me, finding out new, I did have to be a little bit selfish and really just kind of really get my head around it. And so you kind of do have to put your mindset there until you're comfortable.
Thank you.
Okay, so let's move along. We did have somebody on the telephone, but it looks like we lost them. Or did Jake, did you identify the person on the phone? No.
No, sorry, I stepped away, but no, he hung up. Whoever it was, he left.
Okay, well, no problem.
Never did get around to identifying him though.
No problem. Okay, so I'll do a quick. I'm going to do a quick roll call, and then we'll see who needs time today. So we've got Jerry Pelfrey, Dennis Correa, David Dugan, although I don't know if he's still with us, Jim Jeffries, Sylvester Mann, Tracy Saville, Jeff, Marchie, John Ivory, David Muslin, Jim Barnes, Joe Blanchette, Len, Carl, Russ, Les, Herb, Rich, Jackson, and myself. Did I miss anybody? Steve Cavill. Oh my gosh.
You missed me, Peter Kafka.
Yeah, and of course you didn't mention me, but that's not missing me.
I always miss you, Fish. You know I miss you. So
I think it's de rigueur or whatever they say. It's just, it's pro forma.
de rigueur, but you were close. Okay. I know French was never your best language. How's your Russian?
Neplukha.
Good, thank you. All right, so because I missed Steve Cavill and Larry Fish, I'm going to start by asking them if they'd like some time. Mr. Cavill, how are you? It's good to see you again. Would you like some time tonight?
Sure. Look, mainly I think to introduce myself because I don't think I've been in the under 60 group before, but not this group.
Not this one. Oh, okay. Well, then we'll come back to you and we'll treat you like a new man. Because you're a new man. To us, you're a new man. Not to me, but to us. But I'll still go down with everybody right now. Mr. Fish, anything for you tonight?
I am good. Thank you, Rick.
Okay. And I bet I never said Jake's name either. Jake, anything for you tonight?
No, thank you.
Okay. Jerry Pelfrey, anything for you, sir?
Yeah, I'd like to just give a short, quick update. I was with my urology oncologist last week.
Okay. Dennis, Korea, anything for you?
No, thank you, Rick.
Okay. David Dugan, I think, left. Jim, we've spoken to. Sylvester, anything for you?
No, thank you.
Tracy, yes, you have stuff to tell us because you went for your appointment today. We know you do. Jeff Marchie, we haven't heard from you in a long time either.
Yeah, well, 2 weeks ago, I found out 2 weeks ago, I found out I have BRCA2 mutation. Did you know Lupron is in short supply and you can't get a Lupron shot here anymore? Eligard's the only choice.
Okay, we'll talk to you about BRCA and we'll talk to you about other LHRHs. John Ivory.
There's a problem on your website doing donations. If you're on an iPad, it fails at the very end. They actually put it on your as a pending, but it never goes through. I had to use a PC to donate. I just want to let you know, it doesn't work on an iPad. Tried it twice.
Okay, thank you. I will let my web lady know that we're having problems with iPad and donations, but thank you very much.
I am just
Hi,
here to
anything for you?
I'm just here to prostrate myself to your prostate wisdom, all of you.
Is that a yes or a no?
That's a no.
Oh, okay. All right. David Muslin, anything
No,
for you tonight?
no, thank you.
Okay. When are you starting Abby?
Oh, in 2 weeks.
Okay. Okay. Jim Barnes, anything that you'd like to raise tonight?
I just have a quick question for the group.
Okay. Joel, anything you'd like to talk about?
Yeah, I got an update on my PSA and also talked to Yolanda McKinney at NIH today.
Okay. Len, anything you have on your mind?
No, thank you, Rick.
Carl, anything on your mind?
Yes, but I'm interested in hearing other people like Joel talking to Yolanda. I'm curious about that, and also Jeff talking about his recent BRCA2 diagnosis. So I'll be glad to listen in.
Okay, Russ, anything for you?
No, I declared myself cancer-free for this week. We'll worry about it next week.
Okay, all right. And I just want to let all you guys know that Russ was a star moderating Speaking Freely. Of course, none of you knew because no one showed up from this lot to Speaking Freely, and you don't know what you missed. Well, one thing you missed was Rusty being a star. So come in next month when it'll be the Rusty and Rich show.
That's gonna be fun. What a tag team.
What a tag team. All right, speaking of which, Rich, would you like some time tonight?
Slide me into tail end. Should be a quick question. Thank you.
Okay. There's no such thing as a quick question in here, you know that. Herb Geller, anything for you, sir?
If we had time, same thing, quick question.
Okay. Les, back from the wilds of Minnesota, I believe.
Yes, I don't think there's much of anything really to report, though. Thank you.
Okay. All right. Well, I'll put a little question mark there. Peter, anything for you?
Yeah, I have something that might be of interest to people.
Okay. Did I miss anybody? Okay. So we'll start with Steve Cavill, who is, as Steve rightly said, not new to me, because Steve has attended our under 60 advanced prostate cancer group, and he attends from Australia. If I remember, somewhere close to Melbourne, is that right?
Correct. Just on the outskirts, yeah.
Right. So why don't you tell the guys a little bit about yourself, and welcome to this group.
All right. Yeah, thanks, Rick. Yeah, my name's Steve. I'll give you my phone's ringing. God, how long's that? I'll just ignore it. Sorry. I should have it by me. Yeah, so I was diagnosed in 2012, so that's nearly coming up to 8 years now. I was a Gleason 9. My PSA was 20. And interestingly, I know one of the questions before for Jim was, what made you get tested? It was because my eyesight was deteriorating, and my optometrist suggested I should get my blood sugar checked in case I was developing diabetes. So I got my blood sugar checked, and my GP said, well, the blood sugar's fine, but your PSA is a bit high. And I said, what is it? He said 20. And I don't know what you guys thought when you first had a PSA test. I went, okay, like, what should it be? And he said, 2. And I went, oh, God. that doesn't sound very good. So in fact it wasn't, and he sent me to a urologist, and then I had so remember this is in 2012, so things were a bit different. I had a couple of DREs with a couple of different urologists because I didn't like the first guy. Then I had a biopsy which came back Gleason 9 with like 12 out of 12 cause positive, and most of them 100% cancer. So it was, I didn't really have a prostate gland, I had a prostate cancer. And but then I did a technetium bone scan, which was the thing in those days, which indicated that I had tumours in my sacral spine and my thoracic spine and my pelvis. So my urologist, I think, made a good decision at the time, said that there's no point in doing surgery. You should go and see a radiation oncologist and a medical oncologist and hear what they suggest, which is good because I've met a lot of men who, you know, have metastatic disease but have a prostatectomy anyway, which just strikes me as being like, why would you bother? Anyway, so I didn't. I did then have I had body radiation therapy to my prostate, and I had stereotactic radiation to my the spots on my spine. And I started a course of hormone treatment, which was Zoladex, Leuprolin, I think the drug name is. No, it's not. No, it's I don't know how to pronounce these things. Gacelerin. I don't think it's big in the US, Zoladex.
Yeah.
So I had Zoladex for about. Yeah.
It is.
It is okay. Yeah. So I had that and bicalutamide, and I continued the bicalutamide for the whole time. Actually, my oncologist and I agreed. Thought that taking both was actually a sensible idea. And that got my PSA down for quite a long time until I decided I wanted to stop the ADT because I'd had enough of the side effects. So I stopped ADT for about a year, maybe 18 months, and then my PSA started to rise fairly rapidly. It was down to 0.01, and then it got back to, by the time we did anything about it, it got back to 1. And I did more. I did a PSMA PET scan and found a new tumour on a different part of my spine. So we radiated that tumour, and that wasn't terribly successful. My PSA went down briefly, but then started to go up again. So I followed that up with a course of docetaxel chemotherapy and started ADT again. And that was about 3 years ago. And after I finished the chemotherapy and after 6 months after that, my PSA was back to 0 or 0.01. So I stopped the ADT, and in fact, that was 3 years ago, and that's the last time I've had any treatment. And my PSA is now at 0.2. So it's taken about 2 years to climb from 0.01 to 0.2. So I had a PSMA PET scan again in December last year, but it didn't show anything. At that stage, my PSA was about well, I thought it was 0.2, but then when they tested it again, it was 0.18 or something. So it was actually probably a bit on the low side, and it didn't show anything. So our current plan is to wait for my PSA to get to 0.5 and try a PSMA PET scan again. I'm a fan of targeting the actual tumours rather than just taking a systemic therapy, you know, because once you start taking ADT, then your PSA go down and you don't know where the cancer is. So I prefer to be able to find it and decide what to do. Anyway, that's where I'm at now.
Well, you know, my response, and I hope some of you guys, especially some of you more newly diagnosed guys, have the same response I do, is that even when your disease is pretty aggressive, as Steve's was and maybe is, you can manage this disease for a long time. Steve, what did you say your Gleason score was, or did you say, what was it originally?
Yeah, it was 4+5.
So you know, so we have guys that come in and they're besides themselves. We have somebody on this call recently diagnosed, but here's a great example of how you can manage this disease. It's not true for everybody, but for me, listening to somebody diagnosed age 50, 7 or 8 years ago, who right now, I happen to know there's no evidence of his earlier metastasis because I remember that from last time. And his PSA is at 0.2. And if I'm not mistaken, you said you're not even on hormone therapy right now. Is that right?
Correct. I'm pretty sure if I was on hormone therapy, it would be back at 0.01.
Right.
And yeah, so the only reason I'm not is I prefer to know where it is. And if I do another PSMA scan at 0.5 and they can't find anything, well, then there's the possibility that I've actually got lots of micrometastases. So at that point, I'll have to decide whether to do a systemic therapy or not. But it's taken a very long time. Like it was at zero for, well, you know, undetectable, for 18 months of that 3 years. And then it slowly crept up, and it's a doubling time now of about 9 to 12 months. So that's still pretty slow. So I do think the chemotherapy was pretty bloody effective. I'll say that much.
Yeah, and I'll tell you something else, that the thinking around treating the prostate has changed significantly since 2011. And so one thing that you might well be able to do now, and Herb Keller's thinking about doing this himself, he's also metastatic 2 years ago, is that they could radiate the prostate. And they probably
I
would.
radiated the prostate right at the beginning.
Oh, you did, you radiated the prostate right up front.
Yeah, so look, relating to, I think it was, I don't know people's names terribly well. If I hover my mouse, it might tell me. But the AnCan slogan of "Be Your Own Advocate," I think was part of my history. In that, I must admit, the radiating of the prostate wasn't my idea. That was my radiation oncologist's idea. But I went to the radiation oncologist with a paper I found in 2013 talking about oligometastatic disease, because I changed radiation oncologists purely because I went from the private system, which would have been expensive, to the public system, because in Australia we have a wonderful free public health system. Anyway, I went to a new radiation oncologist. Well, the first one mentioned the term oligometastatic, and I don't know if you guys have tried doing any research on the internet, but it's hopeless. Like if you type in, as you know, if you type in any symptom into Dr. Google, the outcome is you're going to die, no matter what it is you had. So searching for prostate cancer, you find Gerson therapy, you find all sorts of nonsense. Oligometastatic is a nice scientific word, and so the only time that shows up is in scientific papers. And I found an article from a guy in Italy who was experimenting with using radiation on tumours, and that wasn't done in 2012 either. You just took ADT. That was it. Anyway, I took that to my radiation oncologist, and I said, "What do you think of this?" And he said, "Oh yeah, I've read that, and I've read another one." But I said, "I think we should do that." So he planned it, and then he said, "So first of all, we'll do 20 doses to your prostate." And I went, "Whoa, why are you doing the prostate?" And he said, "Well," said, "I don't see much point in radiating the tumours if you leave the main thing there. It's like if you've got a invasive weed in your backyard, there's no point in pulling out the little bits here and there. You've got to go back up." But that was a bit experimental. That wasn't standard treatment. So he was good in that one. He was a bit ahead. Then I did this stereotactic radiation, and then I did chemotherapy because of the results of the Stampede trial, which indicated benefit of docetaxel up front. Now, admittedly, at the time it was a bit debatable because the Charter trial showed that if you didn't have high volume disease, it wasn't necessarily effective. But the Stampede trial, which was the UK-based trial, showed that it did. And it was a bit unclear. So being my own advocate consisted of, I actually wrote to Dr. Sweeney and to Dr. James, who were the lead researchers of those trials, and asked them what I should do. And Dr. Sweeney from Charter wrote back and said, "Hey."
Let me interrupt you because I want to get some feedback from the guys for you.
Yep.
And I want to see if they've got any questions for somebody who's clearly done an incredible job in managing really serious disease before we get on to going around everybody. Does anybody like to ask, anybody like to speak to Australia?
Steve, you said you initially responded well after the radiation therapy and Zoladex and bicalutamide, and then I guess you discontinued it. You went on drug holiday, and then your PSA started to rise. So how long was your drug holiday, your initial drug holiday?
Probably, I should have this right in front of me, but I don't. About 2 years.
Okay, and then after that, you had Chemo?
After that, I had a stereotactic radiation to the tumor first, but that was ineffective. The PSA went down for literally only a couple of months and then started going back up again pretty rapidly. So then I did chemo. Yep. And then the chemo knocked my PSA back down to, and ADT combined, knocked it back down to undetectable. And that time I was probably on treatment for less than a year, I think, or about a year. So I started ADT and then did chemo about, I don't remember, 3-4 months later. And then chemo, of course, goes for about 6 months. And then one more dose of Zoladex, and that was it. So, that was the last treatment I had.
So you never had any other ADT except Zoladex and bicalutamide?
Correct.
It's amazing.
Yeah. Look, I know today that, you would probably look at doing something like abiraterone or enzalutamide up front as well, because, the trials are showing that. But I'm also a bit of a fan of if it ain't broke, don't fix it. Like if something's working, it's kind of, I did actually ask my oncologist about abiraterone, and one of the issues of a universal healthcare system is that you don't necessarily get a lot of choice in what insurance will pay for, and so in Australia, insurance won't pay for abiraterone, so it's going to cost, $20,000 a year. So that, I don't have that much money. So, and given I don't seem to need it, I haven't pursued it. And my medical oncologist said, look, given what's working, he said, I think the best thing for you is probably to, if you get a relapse, is to look at immunotherapy these days. And there's although a lot of it's not covered yet by insurance, a lot of it is under clinical trial. So there's an enormous number of trials of different immunotherapy drugs down here, which are then covered, by the trial.
So I'm keeping one eye on the clock here, and I just want to check very quickly if anyone else has anything they'd like to check in with you. If not, we'll move on. But you have a fantastic story, and I really hope you'll keep coming back here, because you are such a poster boy, and you give so much good feeling and good hope to people that are on this call. And we really, really thank you for coming on the call.
Yeah, no, look, thanks. And in terms of hope, I think it does make a difference, because 12 months after, or less than 12 months after I was diagnosed, there's a conference, which I'm sure some of you have heard of, the Prostate Cancer Research Institute, run in Los Angeles every year. And I was diagnosed in December, actually the day before Christmas. So I did learn, don't go to a specialist in November. Anyway, in September the next year, I went to that conference in Los Angeles because I wanted to know what to do. I didn't know what my options were really. And they have a support group at the beginning, and I went to the Advanced Cancer Support Group, and you're probably aware of this, that in your normal local regional support groups, there's not a lot of Gleason 9, there's no Gleason 10, and advanced cancer. And I went to the room, and Joel Nowak, you probably know of, was running it, and he asked people to say how long they'd had their cancer for, who was diagnosed in the last year, and everyone had their hand up. Keep your hand up if it's 2 years, keep your hand up if it's 5 years, keep your hand up if it's 10 years. And there was a guy in the room who'd been taking Zoladex for 17 years, and that's all he'd done with Gleason 9 metastatic disease. And that was an enormous change in my mindset. I was like, oh, I won't be dead next year. Well, I don't have to be. There's a guy been alive here for 17 years. So I know exactly what you're saying, Rick. That changed my outlook completely. That, hey, wow, like there is strong hope that the treatments do or can work.
Thank you. Okay, well, let's go on to some of you other guys who heard this great hopeful story. Yes.
Got one quick question for Steve, since I'm geographically challenged. What day of the week is it, and what time is it?
It is, oh God, you've asked a hard question. It's Tuesday morning at 11 a.m. Now, the reason, I should know the day of the week, but you may not be aware, but Melbourne, for the last 16 weeks has been in lockdown. So people aren't allowed to go more than 5 kilometres from home. No one's at work. because we had a big surge in coronavirus cases. And so we've actually been staying at home for 16 weeks. So it is pretty easy to forget which day of the week it is.
Okay, so all I can say is, Rich, if you've got a bike ride planned for tonight in Melbourne, you missed it. Okay. All right, Jerry Belfry, tell us what's going on.
Well, I just had my 3-month session with my urologist oncologist in Tucson. I go to see Dr. Singh every other, well, it's going to change, but every other 3 months. It's going to be 4 months now. I'll just say this real quick. I found out from my urologist that nobody has Lupron for 3 months. But evidently they do have the 4-month Lupron. And also I found out that Mayo in Phoenix has changed to Eligard. So right now, I just took a 4-month shot of Lupron, and we'll see how that goes. I haven't talked to Dr. Singh about that yet because it was just last Wednesday that I had my meeting. But really, I'll be real quick. None of my labs have really been out of the range of the specific test, other than my protein, which I've been working on, but I'm still out of range by a little bit. It's 5.8. It's a little low. The range is 6.0 to 8.5. So I just can't seem to get that up. But the good news is my PSA is 0.01, and I also did my testosterone, and it's 0.025. So is really good news, and it's been staying that way. And my PSA has been continually going down. But the one thing that upsets me, because I, of course, I've got serious bone metastasis, all the way from my sacrum up to my brain, really. All the vertebrae are infected with the cancer. So I did another DEXA scan, and I did one when I first started, and I was sort of osteopenia. But now, this time, it came back that I'm osteoporosis. So obviously, what that means is I can't fall. So I have a question. Is there anyone else with Gleason 9 that is concerned about osteoporosis?
Hey, I have the Gleason 7, and I take Fosamax once a week.
Yeah. Hold on one moment. Hold on a moment, guys. Hold on a moment. First question, are you taking a bone strengthener? We've talked about...
I was taking it. Unfortunately, my left TMJ started bothering me. And the minute I told that to Dr. Singh, he cut out all the bone medicine. I was on Zometa, and then my urologist put me on Xgeva because he doesn't do infusions. And Singh just said no on any of it. Of course, that is one of the serious side effects. So, of Xgeva or Zometa.
Okay, so we've got a situation here where you were taking, how long were you taking the Zometa for?
I only had a 1-year shot, and then I took a 1-month shot of Xgeva and we spread it out for 3 months because I don't want to drive back and forth to Tucson every month.
Okay, so Zometa isn't given as a 1-year shot. It's given as an infusion. It's a question of how often you get that infusion.
Once a year.
You were getting it once a year, which is not very often if you have bone mets. So that's a little strange. I mean, I got it once a year. I got 3 infusions over 2 years, one right at the beginning, one in the middle, one at the end. But a lot of people, like Jake, for example, are getting Zometa once every 6 weeks. Now, it does have an exceptionally long half-life. And what's usually the protocol now for people with metastatic disease for Zometa is probably every 3 months. You could probably even stretch that out. But once you've been on it for a long period of time, you have a half-life, but you don't have that build-up there. The Xgeva is given as a 4-week shot, I think that's right. Every 4 weeks, or maybe it's every 6 weeks, denosumab. I think it's every 6 weeks.
3 months. I get it 3 months, every 3 months.
You get it every 3 months. Yeah, then it was originally recommended at every 6 weeks, and maybe they've gone also to 3 months with that.
I get it every 3 months as well.
And you're getting Xgeva as well, Herb, right?
Yes, for sure.
Now, the question I have is whether the Xgeva has the same issues around the TMJ.
Yeah, yes, it does.
It does.
I researched that. It has the same side effect.
So now the question is there anybody who has a high Gleason who is not getting a bone strengthener on this call? Dennis, did you put your hand up?
Yes, I did. I also had the TMJ problem in the past, just before my diagnosis, actually. So I've just gone with, as I've mentioned before, the calcium, vitamin D, heavy dose, twice a day. And
That's what I'm doing.
That's kept me out of the osteoporosis issue. I do bone scans every 2 years.
What was your number, Jerry? What was your T-score and where?
Well, unfortunately, Radiology Inc. in Tucson didn't give me the scores. All they gave me was that my left femoral neck was osteopenia, my left 1/3 forearm was osteoporosis, and my left total hip was within normal levels.
So the only place
they say patient is at high risk for fracture.
Okay, so the only place that they were seeing osteoporosis was in your left forearm?
Yeah, it says scan of left 1/3 forearm.
We got to move on sort of fairly quickly here. Why don't you reach out to them and just get the T-score, because you'll need that, because otherwise you can't compare it next time. And just
right, I'm going to get that.
Yeah, have them send you the T-scores. Anybody has any wisdom for Jerry other than Dennis's very good suggestion, which Jerry is doing? Any other thoughts on? Yes, Steve Cavill.
Lots of, I'm not on a bone strengthening agent either, and I did develop mild osteopenia. Bone weight-bearing exercise, lots of weight-bearing exercise, walking, jumping. There's huge study trials in Australia about the benefits of exercise for prostate cancer. So.
Yep. I think that is a good suggestion, but I would recommend that you do it under guidance, especially given that you have in your forearm because you don't want to be lifting weights that suddenly crack your wrist.
Correct. I see a exercise physiologist who sets the exercise program. I think there's a slightly different name for it in the US, but
yeah, yep. So you know, Jerry, talk to Singh and see if he can hook you up with somebody at Mayo to put an exercise program together, a home exercise program together that maybe you can do with bands. Or
we have the bands, and I've got the 2 and 3 and 5 pound dumbbells. I did have, when I was going through the first year of going through this, I did have a very good exercise program put up by the manager of the physical therapy.
I've got to cut you off because we've got to keep moving, but try and go back to that person or do it through Mayo and have them put together a program for you, recognizing where you're living and what you're doing. I think Steve's suggestion was great. And come back to us and let us know what that T-score is.
Yeah, I'll do that. Okay, thank you.
Thank you. So Jeff Marchi, you were saying that you've been having trouble getting your HT supply as well, correct?
Yeah, Kaiser's out of Lupron. I had to get a shot 2 days ago, and they gave me the, what is it, Eligard. And I haven't been getting, I get a Depo-Provera shot every 3 months, and it takes away all those hot flashes. I no longer get any fatigue on a hot flash. I may get a mild warming in my head. I take a CBD pill maybe once a day to stop that. So the Depo-Provera is incredible. But the Eligard, I'm getting these hot spots at night. I'll just warm up and cool down and warm up. But my father died of prostate cancer, and I thought, all right, that's why I got it. And well, as it turns out, on my mother's side, grandfather had pancreatic, 2 aunts had breast cancer and died. One of my cousins had breast cancer and died, and sure enough, that's where I've got it, from that side, not my father's. I'm 10 years in now, and I was diagnosed 10 years ago, had surgery. It lasted for 4 years. I had radiation that lasted for about 2 years. I've been on Lupron for about 3, and I've been on Lupron since March 2017. And it stopped working completely about a year ago. And so they had me take biclutamide every day. And that actually, I went from 0.3 to 0.2. I was at 0.2 for 3 months, and then 0.3 for 3 months, and 0.4 for 3 months. Now I'm at 0.5. I spoke to Harstark at Kaiser, and she says it's time to move on from biclutamide. So I'm having I stop biclutamide. If in 10 weeks my PSA doesn't go down, they'll do a CT and bone scan and then figure out what drug, either a PERP inhibitor or some other thing besides biclutamide that will slow things down. I thought, 5-6 years ago, I wouldn't have this long, but things keep moving on. It's the drugs keep getting better, it seems. I had to contact all of my relatives. I have two cousins on that side that have multiple kids that they have to find out if they've got it. I have my brother and sister that have kids. Both have to be tested, because if you've got it, breast cancer is like 77% chance. It's they tell you get a mastectomy if you're out of childbirth years. So it's just interesting to find out, and the difference is that you end up getting the cancer younger if you have the BRCA2 especially. That's why I got it at 60. or 62, and my father was in his 70s. But at this point, it's a waiting just to see if if 0.5 is the point at which things start to metastasize, or can I continue on without that?
Well, a couple of things. First of all, it sounds like that Depo-Provera is working better than the ice water, would you say?
Yes, though ice water is nice. The Depo-Provera, it takes 9 days about from when you get the shot, because I started to get hot flashes a couple of weeks before. After 9 days, they almost stop completely. And I mean, the thing with hot flashes is just before you get them, you get this fatigue, and then you get the flash, and the fatigue is gone. There's just, I have no negative effects from Lupron at all after having gotten rid of the hot flash. It's
we know and we remember how you suffered with those hot flashes back in 2017, and we felt for you. And I'm really glad that's resolved. Where I feel we have a mea culpa is that you told us about your dad having advanced prostate cancer, and that sent us off the track. We never asked you about your mother and the rest of your family. Otherwise, we would have been telling you to get your we would have told you to get your BRCA test back then, because we were doing that.
Yeah, they say it's only 5% chance of being hereditary if your father has it. Only 5%.
I don't know the numbers. Maybe somebody else on the call does. But
geneticist at Kaiser told me that before I had the test.
I don't know what the likelihood. Well, the likelihood of passing on a BRCA gene is
that's different. 50-50.
50-50, or 100% if it's on both sides. Well, no, I don't think it's 100% on both sides. I have to defer to Len or Herb if it's on both sides. If it's on both sides, is it 100%? No. You're muted.
Anemia.
75.
75. Okay. But having said that, the PARP inhibitors are very effective. And just to let you know how effective they are, Carl, do you want to talk about how effective your PARP inhibitor has been?
Well, as a result of genetic testing and my being diagnosed as BRCA2 positive, as a result of precision medicine, it was determined that I would benefit from going on to olaparib, the PARP inhibitor, which I've been on over a year and a half. For most of that time, the PSA had been undetectable. More recently, over the past 2 to 3 months, I'm having more of a challenge with the PSA slowly going back up, and we're determining what the next course of action is going to be.
Yeah, they report a 2-year, that it's good for 2 years, don't they? Those types of drugs is usually about.
Well, my understanding that olaparib, I'm well beyond. It was typically 8 months, and I'm well beyond that 8-month time frame.
Okay, thank you. What else do you have any idea what else they're considering?
Well, what I'm considering actually is I'm looking into getting a PSMA scan, and I'm doing research about that, and I know that Peter here is working on that as well for the group. So I was actually given a 5-day reprieve on the olaparib within the past week to see whether my side effects would be mitigated from then, and it appeared to take that effect, but I was concerned that by being off of it that my PSA would rise even further. So don't know yet, but my next appointment is in a month. So we'll see what the blood work says. My oncologist has also said at some point in the future, at the Cancer Institute of New Jersey, they are working on a relatively new clinical trial with Keytruda, and for people who are BRCA2 positive. So I may at some point get on that trial.
So let me come back to Jeff. You know, I think that the choices out there for you are definitely a PARP inhibitor. If you did say you're BRCA2, right? Not BRCA1.
Yes, BRCA2.
BRCA2 has the highest response rate to the PARP.
Yeah.
And then of course there are the second line anti-androgens. What I really don't know enough about is whether the side effect from giving those two drugs in tandem is too great. Does anybody know anything about giving a PARP together with a second line anti-androgen? It's not. Len, are you there?
Yeah, sorry, I just got back. I don't believe that's an issue. Of course, anemia is a problem with olaparib, and ADT can cause some degree of anemia also. So that would be additive to the anemia problem. But I don't believe there's any other toxicity that you'd have to worry about with that combination. I don't know, what do you think, Herb? Do you know about anything about this?
I would not think they have overlapping toxicities, but that's just because of what I know about them individually. But anemia is always there.
Yeah.
What does is there a drug to take to offset the?
Hold on a minute, Jeff. Dr. Mark, have you got any input on those two drugs together?
No, I don't. Again, they're different pathways. Anemia is something you could see in both, but I don't have any experience to add to that.
Okay, thanks. Go ahead, Jeff.
What do they do to about the anemia issue? Are there drugs for it? You got to get blood transfusions every few months? No.
I do have some anemia as a result of the olaparib, but there's no treatment at this point because I'm borderline. I'm below normal, but not too far below. But if I was too far below, I was told I may very well have needed transfusions, but it's not in my cards.
Does it cause energy problems?
Oh, yes.
Okay.
The other medication would be Procrit, and that could be utilized as well. Again, I don't have experience using that, but it may be something that the medical oncologist would consider.
So let's just go on this energy problems, which is that, you know, abiraterone can also cause significant energy problems. It does for some men, it doesn't for others. We've got men on here who have been crippled by the fatigue. We've got men on here who have been crippled by the fatigue from enzalutamide. So, you know, all of these drugs may have energy problems. They may not, because everybody responds differently. The PARP, some people do real well with them, other people don't. But I think this is what you got to weigh up. I think what we don't know, I'm not sure there have been any trials of whether men with a BRCA do better on a combination versus just one of the drugs. In other words, BRCA and say Abby together versus BRCA alone or Abby alone. But you know, we do have a fair amount of information on BRCA on this call, in this group. So I just say to you, Jeff, just keep coming back and tell Andrea we said hello when you see her. And
on Zoom.
Yeah, oh well, when you see her on Zoom, you know, tell her we said hello. And go through it with her. She's knowledgeable, and, you know, see what she recommends, whether she recommends a second-line anti-androgen or a PARP inhibitor.
Yeah, we have to figure out first if it's metastasized. So that will go through in about 10 weeks if my PSA has not gone down.
Yeah, I mean that that if it has gone up and you don't show any metastasis, then you'd be a candidate for darolutamide, which is an excellent drug, which probably isn't going to make you feel quite as fatigued. So that's
Yes.
another option too.
I mentioned that to her.
Okay.
Yeah, I'm also aware that there are clinical trials combining olaparib with abiraterone. I know that my institute here in New Jersey is participating in that. So there are clinical trials going on with those two medications.
Wow.
Okay. 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 So let's go on to Jim Barnes. You had a question, Jim.
Yeah, my question was, where I'm, still trying to find where I can get the PSMA test at. And I was looking for suggestions somewhere in the Northeast here. 6-hour drive from the, a quarter or more population in the United States. I'm just thinking there has to be some place, drivable to or a short flight to. The only place I've heard that definitively has them is UCLA. Just one other thing on the Lupron shortage. I got, I was supposed to get Lupron 3 weeks ago and they gave me Eligard instead. So I concur with everybody's observations there.
Yeah, and I don't think that there's never been any studies that show a significant difference between any of the drugs other than Firmagon or other antagonists. So all of the agonists seem to work differently, and sometimes men find when they stop responding to one, they try another, it may work, but by and large, I don't think it's anything to be concerned about. Peter, any information on a PSMA scan in the center or the east of the country?
University of Indiana has a couple of trials going, Jim. Look them up on clinicaltrials.gov. There's 2 trials at the University of Indiana, and it says by invitation. So get the phone number and email from the researcher, doctor who's running the trials, and find out, ask how you get into this, because they're both open for different stages of disease. So that would be the closest to you. It's only, I know it's a drive, a short hop on a plane, but it's a one-day thing. We don't have to spend the night. It's not that big a deal. So that would be the closest, I would think, to the University of Indiana.
Okay, Jim?
Yeah, good. That was clinicaltrials.gov.
Okay, yeah. Do you know how to use clinicaltrials.gov?
No, but I'll figure it out.
Okay, so we have a webinar that's recorded that talks a lot about how to use clinicaltrials.gov. Jake is always good at finding it, so maybe he'll just post it in the chat window, and it'll help you a little bit. It's like a part of the webinar is about a primer on clinicaltrials.gov. And Mark, Dr. Mark, you just posted in the chat window that Emory in Atlanta and Columbia, is that New York Presbyterian? You're muted, Mark.
Okay, it is Columbia University, so I assume it's the Columbia Presbyterian Hospital. Again, it's listed under clinicaltrials.gov. I was not eligible because I didn't post the Tulsa Pro. You need a PSA above 2 for that program at Columbia. They are also doing liquid biopsy with it. Emory is using a tracer called PSMA They have another trial that looks at Axumin, but that's not the trial you want to look for. So they have 2 PET scan trials going now. And again, clinicaltrials.gov will get you to the right one.
Yeah, I think that's really more Weill Cornell, which is affiliated with Columbia, because I was just looking at that earlier today. And there's a Dr. Scott Tagawa, which I shared with Len, who is the principal investigator. And there are 3 different PSMA trials, which I am looking into possibly pursuing to join them. But also earlier today, I found out that Mount Sinai with Dr. Tawari, it hasn't yet been published, but over the next day or 2, it may very well come out as an additional location for a special PSMA trial, which looked like the closest to me in New Jersey was Towson, Maryland. And I called up the person from the clinicaltrials.gov, and he said, oh, we're going to be opening up at Mount Sinai. So that's how I found out about that.
Thank you. Thanks for posting that, Jake. I got the link.
Yeah, thanks, Jake. Thanks, Emil.
My pleasure.
Okay, so I'm going to keep moving along here because we've given Jim Barnes plenty of homework to do. Let's, Jake, since you're with us right now, you had a quick question.
Yeah. If it's okay, can I share my screen for a minute and show you a picture that my son took of this rash I have on my hand? Maybe somebody that's had chemo will recognize it, or maybe Dr. Perloe will. Can I do that real quick, Rick?
Yeah. Who was it that was complaining to us? Oh, Ken Anderson, who had the foot and...
I had it.
Oh, and you had it. Okay.
So I might recognize it, I might not.
Okay, show us.
Can you see that?
Yes.
Oh yeah, that's what it looked like. That's what my hand looked like, Jake.
And what did you do?
Well, I mean, basically there's cream for it, and there isn't much you can do, and hope that it doesn't get worse.
I had that like 10 times worse.
Really?
Well, like my hand was like swollen to 2.5 size.
Larry, did you have it on your feet?
I had it on my feet also. My feet were more the nails and neuropathy and some rash, but my hand swelled up so bad that I had to stop doing chemo. Well, I ended up stopping without finishing the course. We could have lowered the dose and spread it out. I just went back to Lupron, and it was like initial treatment, Lupron and chemo.
Herb, what was it?
Larry, you and I had the same situation. That basically after they saw that, they said, let's move you off.
Yeah, they took me off.
And they started me on abiraterone.
They took you off chemo, Herb?
Yes.
Okay.
After they looked at that rash, they said, you're not going to be able to tolerate this anymore.
But that was what it was like to me, and then it got worse and worse. And it was the winter, and I couldn't put a glove on. I couldn't put my hands in my pockets.
It's very weird. It's kind of numb to the touch, but then it hurts at the same time.
Right. And the other thing, Jake, is that unless they're a medical oncologist, they're not with significant experience, they won't know what it is. My sister-in-law is a pediatrician. She looked at it. She said, I haven't a clue.
They start to have the last 3, 5, this was 5, 6 years ago. They started to have, like, you wear ice gloves during your chemo. They had some things that you do so that the chemo doesn't get down to your fingers and your toes so fast. there's a number of, I don't really know what they are because I'm so far away from that. But they started to talk about like wearing ice gloves to slow it down, slow the process down to your hand so it doesn't go in there.
Jake,
You could see like a dermatologist specialist recommended by an oncologist.
Jake, have you talked to Ken, because he went through this a couple of weeks ago?
This is 5 years ago. Okay, I'm gonna.
The rash on his hand, on his hands.
Yes.
No, I have not talked to Ken. It started about 2 days after I had my last chemo, almost 2 weeks ago now. My son took a picture of my hand, as you saw, and I sent it to my oncologist, but she hasn't responded. I do have an appointment on Wednesday for chemo. But are you guys saying it's a rash? It's an allergic reaction, or?
We're not quite, I don't think the etiology is known. I tried to do some reading about it and I came up with a blank. Just essentially, it's a reaction to the chemo. Now, again, it may be that they'll give you your next dose and just say, let's see what happens if it's not that serious at this point.
So a couple of people that we know have had some success using steroid cream. It's possible that steroid cream will settle it right down. That's one thing to discuss with her. Guys have mentioned that. Ken told us it was called foot and hand. If you listen to, I think it was 2 weeks ago, we talked about it.
Yeah, I do remember that. Yeah.
He says it's called foot and hand. And then, for Herb and for Larry, it caused them to stop. But I think that she needs to, when are you supposed to see her? This coming Wednesday?
Yes.
So, I think I'd reach out to her tomorrow and say, do you want to give it to me or not? And, what about some steroid cream, or what else do you suggest?
Was this the hand that
I do need to go in to get a blood test anyway. I want to find out what my PSA is. So I'm going to go in Wednesday no matter what. But I'm just concerned it's an allergic reaction that's going to get worse. I tried to find it too. I found a hand and foot thing. I found a thing called erythema. I don't know.
Erythema is just I don't have to explain it.
I think you've got to talk. I mean, we don't encourage people to be Dr. Google. I know everybody wants to be, but you get yourself down, you get yourself into side waters and cul-de-sacs, which aren't particularly good. What you've got to do is either speak to your doc or have your doc refer you immediately to a dermatologist, and preferably a dermatologist who does a lot of work with cancer, and go from there. Dr. Mark, did you want to say anything about this?
I was just wondering whether this was the hand that you had IV placed in the hand, because you can have local reaction at the site of a vein. If that were the case, I'd certainly bring that up, as opposed to this was happening in multiple locations and not just where the IV was inserted.
It was just it is the hand that they did they're running out of veins, so they use my hand, and that's the hand that they did it in a week, 10 days ago.
Yeah.
12 days ago.
And that's a great spot by Dr. Mark, because maybe there was some leakage and the docetaxel aggravated the hand. And maybe that's what it is. But that's why I don't want to play Dr. Google here. And you've got to be talking to your doc, and you've got to tell her, could it be from the vein, where they insert the vein, or could it be from an overall reaction or what have you, and let her decide. But she needs to pay attention to you.
Okay, thank you.
Okay. Anyone else? I think we got everybody's response on that, right? No one else?
Where's Ken Anderson when you need him?
What's that?
Thanks, guys.
We're sitting here with bated breath. Tracy, tell us how you did. were you your own best advocate? Do you have a T-shirt yet? Do you have a T-shirt?
I don't have a T-shirt yet, but I will be getting one.
Okay. How did you do? And first of all, how do you feel this week?
I feel actually much better. So last week was I had my first treatment with Firmagon and had been taking Casedex for about a month and a half. And I went and had my blood drawn and the testing done. And my PSA went from 711 to 1.34. And my testosterone dropped from 455 to less than 5. My platelets jumped from 82 to 165, so I can actually, feel good about that. And the hemoglobin went from 8.2 to 8.6. And
Okay.
so I am.
Can we just run through those again? So your PSA dropped to 1.54, did you say?
1.34.
1.34. And your testosterone went down to?
Less than 5.
Less than 5. And your platelets went up to 134,000?
100 went up to 165, so 165,000.
Wow. And how long is that after you started you had your first Firmagon shot?
That was probably about, I would say maybe 35 days. I think I had it on like the 20th of August is when I had the first shot.
Well, I want to tell you something because there is research on this. To get a response like that is really bodes well. Really bodes well.
Yeah.
I can't cite you the research right now because it's quite old research, but they have done research that shows that a good response, a rapid response to an LHRH drug means that you will do well, that your cancer is responsive. Len, do you have any input on that?
I think you might be thinking of a study that was done, I don't know, maybe 5 years ago, where they felt they were able to predict how well you would do if your PSA was brought down below 4. It was below 4 or below 2 within 7 months. So obviously Tracy's clobbered that goalpost, so yeah, that does bode well. It shows that a huge proportion of your cancer is of the garden variety PSA producing kind rather than PSA resistant, ADT resistant. So I think that does bode very well. And I suspect the reason why your platelets have gone up and your hemoglobin's gone up is because the cancer is being cleared out of your bone marrow. So this is all very good news.
Yeah. Last week when I was reading numbers off, and I could just tell off of the couple support groups I was on that people were like, "Oof, that sounds terrible." And when I got my test results back, I was just ecstatic because I knew immediately that, like, hey, this is a great turnaround. And so when I went to my oncologist today, we've decided that we don't need to move into chemo right away because of my response. And basically, I'm going to be doing the Firmagon and move on to Xtandi. So that's the enzalutamide. And so I should be starting that soon. And we'll keep going with that. If we need to make some changes at that point, we can go to my genetic research information and change to some specific drugs that they recommended there. I'm a good candidate for a clinical trial at the University of Rochester, and basically they're, the benefit of treating the prostate, after, you have, bone metastases. And so it's either going to be radiation or surgery or nothing. So so there's an opportunity for that 6 months down the road. And the chemo was docetaxel. So that was one thing that I did look into. And I did ask again about the Gleason score. They weren't able to get an aspirate when they did my bone marrow biopsy. So I think that maybe, I'm not sure if that's interfering with the Gleason score, but it's definitely greater than 8. And so that's where I'm at with that.
So a couple of things I'd like to just say to you. First of all, you don't need to be in a trial to treat the gland. And frankly, if it were me, I would only be considering radiation. Carl Foreman may have a different opinion because he did do surgery through a trial, but you don't need to be part of a trial to treat the gland. They should treat the gland, and you should discuss whether you're a better candidate for surgery or for radiation therapy, and go from there. And we can help you make that decision. But
yeah, and I do have time for that. It's not for 6 months before I'd even be able to, apply. And
right.
So I have time to make a decision about that.
Right. Secondly, the research that's come out recently definitely suggests that abiraterone, it's better to start with abiraterone than with an androgen receptor blocker. And I don't have that research at hand, but I can tell you, because I've heard it mentioned by a bunch of guys, a bunch of medical professionals, that you do better starting with abiraterone and going to enzalutamide than the other way around.
Okay.
And there is research to back that up, and you can reach out to us. We can see if we can find it, but I think it's around. I think
I can certainly find. You're absolutely correct. It's around. I've read that paper.
Yeah.
Okay. I'll definitely research that and make sure that one, that I understand it, and two, that I get that information up to him as a form of a question, because my responsibility, it really bothers me that it was discovered late, and I own a part of that, and I'm not going to allow any sort of situation like that to happen again.
Now,
Tracy, you may ask your doc about the abscopal effect. Rick, you mentioned about treating. I'm not sure potentially that avoiding radiation therapy, which you could begin now, might not be beneficial. You might ask about that effect where they treat the gland, but there's a benefit distally away from the site of treatment because the radiation may enhance the immune system. So I'd ask the med onc if that were appropriate to consider.
Okay. And he even said that he was surprised that he was changing the direction here a little bit, because he was, my full intent today was to go in and start getting ready to start doing chemotherapy. And based on the response, he was wanted to hold off, so and keep it for a later option. But I was wondering about that, because a lot of people have said if you do the ADT and the chemotherapy sooner together, you do have a better response. So I was kind of questioning about that. So I need to learn a bit more about that.
Well, the answer there is it really depends on the volume of your metastasis. I mean, the studies show that if you have the studies are not related to the speed at which your testosterone comes down. They're related to the amount of metastasis. If you have low metastatic volume, you're better off with a second-line anti-androgen, probably abiraterone. If you have high, then you're better off starting with chemo. So the real question is, how many spots did you have? I know it was in your hips, your shoulder, your lower spine. If it lit up like a Christmas tree, then I think most GU med oncs would still stick with the chemo. And that's why, we still encourage you to get a GU med onc and to go get, before you start the enzalutamide or the abiraterone, please speak to a GU med onc. Listen to the podcast that's on our site, the discussion between Chris Sweeney, Chuck Ryan, and Alicia Morgans. I think I sent that. Did we send that to you? Did we give that to you?
I don't think I have that.
I gave it to someone last week. I can't think who. If one of you guys, Len or Peter or Jake, could just go to Prostate Cancer Resources and just put the link to that discussion in the chat window for Tracy, that would be great. And Tracy, when you have a moment, look through all of those links under Prostate Cancer Resources. Those were the old links we had on our old website. We haven't done a great job in transferring them in to the new website. They really each need a new blog post of their own, but who has time to do that?
Yeah, I did dig into my oncologist background, and he has over 30 years of treating prostate cancer exclusively. And I went in and I read a lot of patient reviews and stuff like that. So I feel more comfortable with him than I did because I just didn't know. And but I am there's another individual in Rochester who I may go and get another second opinion with. So, but I did look at like some of the GUs around. I just need to kind of get my head around that a little bit more.
Okay, so the GU med oncs that are around, we can guide you to the right ones. Len's put a link in there, but that's not the link we really wanted. The link we wanted is the one that's at the bottom of the prostate cancer page that says Prostate Cancer Resources. And if they don't get it, I'll send it to you later.
I'm looking, Rick, but I can't find it right off the bat.
Okay.
I'm not sure exactly which one you're thinking of.
So if you go to prostate cancer, everybody, this is helpful for everybody. If you go to prostate cancer groups and you scroll down to the bottom of that page, you'll find something that says, click here for a complete list of prostate cancer resources.
Okay.
And if you click on that, there's a whole bunch of old links that we put on, and the link you want is Zytiga Xtandi or Chemo First. And I'm going to copy that link and I'm going to put it in the chat window for you right now. And it's right there. And I just recommend everybody look at some of those resources. And if anybody wants to volunteer to make separate blog posts for each of those resources, I'd be happy to show you how to do it. But there's a lot of work. It's a lot of work to do that. And that's why they're hard to find. We apologize. It was just something that became more difficult to find when we created a new website. But yeah, Tracy, you're doing great. We're all really happy for you. But just make sure if it were me, I'd be setting up a consult in Chicago or in Boston or in New York sooner rather than later, and asking them what they do. I mean, that link that I gave you, Alicia Morgans is in Chicago. We can set you up with her. Chris Sweeney is in Boston. We can set you up with him. Chuck Ryan is in Minneapolis. We can set you up with him. But that's the level, the sort of quality of doc that we really would like to get you to.
Okay.
And I think you're fine right now, but we got to get you on to either chemo or a second-line anti-androgen sooner rather than later.
Okay. Okay. Well, thank you.
Is there anybody? It's 7 minutes past 7. I'm sorry we've run over. There were a bunch of people who said they didn't have anything that important. It could wait till next week. Is there any? I will stay as long as is needed. Is there anybody that wants to bring something up right now that Peter, Rich, Herb, Carl, Joel? Is there any of you would like to bring anything up?
Yeah, this is Peter. I'll just mention quickly because this might apply to Jake with the hand issue. I wouldn't recommend it until you really research and talk to a doctor. But the other day I had a reference for a good what do you call them? The people who stick needles in you.
Phlebotomist.
Huh? No, not a phlebotomist.
Acupuncture.
Yeah, acupuncture. I went to an acupuncturist here. She was really good for my neuropathy in my feet. And it's one treatment so far, and it's made a considerable difference. It hasn't gone away, but I can feel the difference. Just 3 days later, walking out of her office, I'm going to go again next week, and just continue on. It's made a difference in my edema and my neuropathy in my feet. So I just want to mention it. I know it's something that we suggest once in a while, but I've never tried it. No, I never had a need to, but I have now.
Thank you, Peter. Yeah, we know that people who have got response before from acupuncture, I think the big issue there is that you probably need repeat treatments because it wears off after a while. So you have to be ready to go back. But yeah, I mean, we totally support this complementary approach. We think it's great. But thank you. Any questions for Peter about the acupuncture?
Just one
Did
thing.
you fall asleep on the table? Every time I have acupuncture, I'm out for like 45 minutes.
I could have, but I didn't. It's I was pretty conscious during it.
You know, it must have been those beautiful Hawaiian ladies that were standing there fanning him with the big pineapple fronds, you know, that kept him awake. Who knows? And Joel, was yours something that you needed to talk about now, or can wait?
Yeah, just 5 seconds. I talked to Yolanda McKinney today, and she has no idea when the NIH is going to resume the PSMA testing. She said that nothing at all for external patients, but they'd still do it for internal patients, whatever that means.
Herb knows what that means. Herb, do you want to explain that to us?
NIH is really on lockdown. I'm not allowed to go to work. I am working from home. They don't let me on campus. They want the campus census as low as they can possibly be. Our area, COVID is not dropping. It's pretty stable, and until it drops, I think NIH isn't going to change their policy. So, to be honest, I don't see it dropping until spring, if it happens at all. people are not paying attention, and so NIH is being super cautious.
And for Steve Cavill's benefit, NIH is the National Institute of Health. It's one of the major research facilities in the United States. Okay, anyone else?
One quick one.
Well,
yes. I'll come to you, Herb, next. Rich Jackson, a quick one.
Tomorrow at noon, I've got a needle biopsy of the groin lymph nodes. I'll be loopy enough, I won't care until they finish, but I plan on going back to work Wednesday. Anybody's had any issues with that?
Well, I had a bone biopsy and I had no issues whatsoever. Just a couple of hours after the procedure was over, I was fine. I don't know. Okay. I've never had the inguinal biopsy.
And it's not sure how much fishing they may have to do with the needle. It'll be CT guided, but they're still, they're shooting for a small target.
How big is the target, Rich?
One's 0.4 centimeters, other's 0.5 centimeters.
Okay, 4 millimeters, 5 millimeters. Yeah, that's right on the limits. Rich, did you win anything at the weekend? That's what I want to know.
Of course. We brought second in the Spirosaurus contest.
Well, wait a second. If you're that good at Spirosaurus, maybe you should do your own biopsy tomorrow. What do you think?
They won't let me use my favorite anesthesia.
Well, I'm pleased to. Are we going to get any pictures of you and your? Was it silverware you brought home, or a shield, or what you bring home?
You have to come to see what goes on.
Oh, boo. Okay, no pictures, and we can't lie, you meanie. Okay. Well, sir, I will check in with you. I'll make a note, but I hope it all goes well tomorrow. Has anybody else had a biopsy, either solid or soft tissue on the call? Herb?
I've had a bone biopsy, and I was, after they let me out, I walked over to my office, and I didn't notice anything.
Okay.
So,
thanks.
I think
Thank you.
Okay.
Yep, I had a bone biopsy and nothing. I didn't even notice there were, there was any issues whatsoever.
Thank you, Tracy. So I think you got it down. And let me just tell you, if they do have to start fishing around, you get out whatever you use to spear that saurus and poke that interventional radiologist with it, okay?
I'll have to take Brenda with me. She was the one throwing the spear from the back of the bike.
Okay. Well, I think you should take Brenda with you, to be honest. She's going to go with you.
She's got to drive home.
Okay. Okay. And Herb, you had a question.
Well, I think I'd like more advice about radiation. The reason I'm saying this is because the clinical literature right now, I read almost everything known. There's no clear-cut indication that it's beneficial. And my radiation oncologist at NIH is very much into data-driven medicine, and so feels that I'm borderline, that basically reading the literature, she's not sure it's going to do any good. She's pretty sure it won't do any harm. So I'm leaning towards doing it. And Mark, I need to talk to you more about the abscopal effect, because I can't find a whole lot about it in the literature either. So I'm leaning towards it, but I had a consult, it was like an hour and a half conversation with a radiation oncologist at NYU who said the same thing. He'd happily do it, but if he were advising me, he would say there's no reason to do it because there's no literature to support doing it. So I'm, being my own advocate, I really appreciated hearing about our Australian colleague because that really said, that's how I felt. Well, I don't need this primary tumor. I want to get rid of it. But then the issue is how many gray do we use? Does anybody have any experience with how many gray to use in a situation like this? What do I tell her? So that's my issue. We could leave it for next week, just think about it, but because it's late. But I'm really needing some help here to go back with some ammunition and saying, this is what I really think we should do.
So I think we should speak about it next week because I think it's an issue that needs unpacking. But I want to ask you to do one thing. Go back, and I know you listened already, but go back and listen to Mac again from the Saturday session, right? Because he spent quite a bit of time, and I think it was towards the end, and I think Moyad asked him about treating the gland, and he got into it. Now, I think he quoted some studies, but I'm not sure. If he did, there's a lead for you. If he didn't, then between you and me, we'll get to Mac.
That would be good.
All right. So you and I can write. You can write to him. I'll give you his number. I'll give you his address, and you can tell him that I recommended, or I'll write to him and tell him, heads up, this is one of our NIH scientist guys who needs some help here, and we need data. Here's the big problem is that, and it's the same thing with the abscopal effect. It is fuzzy, but it's becoming less and less fuzzy because more and more very reputable doctors are picking up on it. And one of them is Mac. And it just seems like it's the way to go. But I'll be in touch with you. If you haven't heard from me by Thursday, remind me.
Great, thank you.
Piece of paper. Okay. Mac Roach for Herb. And let me just check with Mark. Mark, did you do okay when you went to California?
Well, I'm in there now. I got my, they develop a brace for you, and I had the CT, MRI. I talked to Dr. Keyshawn again on Thursday, and Friday is the first treatment. So I'm beginning the journey. I have the genetics from SEMA4 pending, looking at 15 different mutations. I've looked at Foundation 1, so at some point I'd like to learn more about that. But I'll know a lot more after Friday.
Okay, when you're ready to talk to Foundation Medicine, let me know. Okay, whenever you're ready, send me an email, and I'll hook you up. And maybe you can ask Keyshawn too whether he's aware of any evidence for treating the gland.
Right, for the abscopal effect on that.
And the abscopal effect and treating the gland. Yeah, that'd be great.
Yeah.
Okay.
And I actually use Foundation 1 for my genetics.
Oh,
report.
did you? Good. Okay. Okay. So, yeah. All right. That's it, guys. Sorry to run 20 minutes over. My apologies. And the next meeting is not next week because next week's a 5th week. So I don't think our next meeting is until October. It's going to be the first Monday in October, which will be the, I think it's the 5th. Yeah, it is the 5th. If anybody has anything urgent between now and then, just reach out to us. Okay?
Thanks, John. You always run a wonderful group. Appreciate it.
Yes, it's a great meeting.
Thank you, everybody. Good night.
Bye.
Let Jim.
Good night, good night.
Good
Good night.